So maybe let's start by asking you if you could remind us the trial design and the timing of readout, because I think this will be an important readout for the CB1 space.
Okay. Yeah. Well, just before I just want to get people oriented here on just a couple of things, Umar and Lisa, thanks again for inviting us and giving us the stage. We're working on a drug called Nimacimab, which is a peripherally restricted CB1 antibody. It's a first in class. The space has been primarily the discussion has been dominated by the small molecule CB1 space. So what's exciting here is what Umar's pointing to is a phase 2 study that's underway that's evaluating monotherapy and combination. And Dr. Arora, Chief Medical Officer, can walk you through the design. I'll touch on just a couple characteristics that are important to watch for in this study design. One is efficacy. This study and generally what we've observed with Skye, the efforts that Chris has been leading and what we're presenting at ADA is a really solid and undisputed kind of evidence in now multiple DIO studies that show that we're seeing fat selective weight loss with lean mass preservation. That's now been also anchored with this early phase 1B data that we had in NAFLD, where we highlighted in a diabetic and a pre-diabetic population about a negative 2.8% placebo-adjusted weight loss. And that curve is similar to what you see in GLP-1 in a similar population. And then the data that's going to be presented tomorrow highlights in combination with a low-dose tirzepatide showing with Nimacimab that we're seeing about 31.5%. So efficacy is the number one point. The other has been tolerability, and it's been kind of discussed in the panel before us that if there's a key characteristic that we're watching for is that continuation and utilization of these anti-obesity medications is where we ultimately want to see long-term adherence, and we think that Nimacimab and the data shows an excellent safety profile. Again, based on phase 1 data, less than 5% mild GI side effects. And we have some head nodders in the audience because they've been familiar with the data as being developers in this field. And then the other third area has been the safety profile. So one of the challenges, as pointed out, is in the small molecule space has been still a concern of brain exposure and adverse event profile. And again, pointing to our clinical data, and we can talk about what we're seeing so far based on the safety information we have in our current trial, is in our trials, 0% in our phase 1 trial, 0% neuropsychiatric side effects, and it's been backed by a really strong.
Sorry, that's in phase 2?
This is in our phase 1 study.
In phase 1,
yeah.
okay.
But Dr. Arora can maybe kind of highlight what we've been observing based on Data Safety Monitoring Board interaction and at least in terms of general information. But the preclinical evidence here is that we have a unique PK profile. We've shown that we're staying 99% out of the brain based on a whole toolkit of different data, PK information, PET imaging, biodistribution data. So you have this really strong information. I'll turn it over to let Dr. Arora say something about the trial design.
Sure. So this is, we're currently running a phase 2A clinical trial for Nimacimab. And this trial is a proof of concept or a proof of mechanism trial, as you may choose to call it. So we are studying a single dose level of Nimacimab with the purpose of comparing it against placebo. So it's to begin with, it's a blinded, randomized, placebo-controlled trial. We have two arms in the study, so to say. The primary arm of the study is Nimacimab, 200 milligrams given once a week, versus placebo. The second smaller arm in the study with more exploratory objectives is Wegovy for everyone, so semaglutide for all patients, and then either Nimacimab or placebo in a randomized, blinded manner. So here we'll get an early comparison of what happens with a combination of semaglutide or GLP-1 with Nimacimab versus semaglutide alone. So this will, we have 120 patients in the trial. It's fully recruited. There's 80 patients in the primary arm and 40 in the combination arm. We should have data on this in early Q4. We're clearly in a trial that's at phase 2A, especially for a CB1 mechanism, given the history, safety is paramount. So I'm going to address that for a moment first. We have rigorous safety evaluation on in the trial, negotiated with the agency. There is a series of questionnaires and tests that are done in all patients on a regular basis. These include cognitive tests, mood tests, neurological examinations, questions about general well-being, physical ability. So these are all being done regularly. We have an independent data monitoring committee that sees unblinded data on a quarterly basis. They've completed 3 reviews of the data already. There's a 4th one coming up in less than a month from today, and we've had no concern from them. They've told us to continue the trial as is being run today. From our point of view, I mean, we can only see blinded data, but all I can say to you at this point is just overall safety and tolerability has been great for the trial, and I feel confident just looking at the blinded data, pooled data as it stands today, that Nimacimab will be well tolerated, and we should be able to show a good safety profile when we actually put out the data in Q4.
And Dr. Roy, you can see blinded mild to moderate neuropsych effects.
We can see, so
which was the observation on the Noble?
There's many of these events, because we are doing all these tests, are designated in the trial as adverse events of significance. So they get reported, and frankly, we haven't seen anything of alarm or anything that would trouble us in the trial at this point. And we're most of the way through the trial.
Can you talk about when you do report data in the end of 3rd quarter, early 4th quarter, how much weight loss are you hoping to see? What are you hoping to see when you add on to Wegovy? And any other benefits that you think CB1 antagonism brings to the?
So just to go back for a moment, we are treating for 26 weeks, and after I finish addressing that, we'll talk about the extension to this trial as well, which I didn't get a chance to do. But we powered the trial, and these trials are, especially at this stage, we are going to describe the difference in the end between a placebo group and Nimacimab, or with the combination. But in order to size the trial, we powered it for an 8% difference in the monotherapy group between Nimacimab and placebo. At this dose level, we believe that anything between 5 and 8% will be really positive for us, with a strong safety profile and no neuropsych events coming along with it. We're also looking at that combination study, and what we really want to see there is additive effects. We want to see proof of additive effects. The trajectory of weight loss with this mechanism may be different from GLP-1s, because GLP-1s in the end, just with a real world analogy, is like going on a crash diet. So there's a certain, because you're suppressing appetite, right? So there's a certain trajectory to how you lose weight with that and how it plateaus, etc. This is different. There's a different balance between the peripheral mechanisms and the central effects that will come despite the fact that the drug doesn't cross the blood-brain barrier. So what we're looking for clearly is those additive effects, that it's complementary, largely peripheral mechanisms from Nimacimab and largely central mechanisms coming from the GLP-1, coming together to give these additional effects, which we hope that at 26 weeks we will be able to see.
Are those placebo-adjusted numbers? Is it 5 to 8%?
Yes.
Okay.
Yes.
And since it's an antibody, we would expect it to be more peripheral in nature, but antibodies could still have a very, very tiny fraction, still make it past. So my question is, I believe because it's an antibody, half-life is probably around 20 days. So when you're dosing it weekly, what's the accumulation effect from a PK perspective? How are you thinking about that?
Yeah, I mean, there's clearly some accumulation that's going on. Our modeling in general, and I know Chris can talk a lot more about this, we actually had a great poster at ECHO 2 a month ago where we compared the peripheral and the central levels of Nimacimab with rimonabant and monlunabant, and what happens there. We have done biodistribution studies in non-human primates and shown that there is minimal or no accumulation in the brain. So, and that's at much higher doses. And we intend to repeat these at some point in humans as well to demonstrate the same. At some point, when you go higher and higher, yes, there's going to be a little more in the brain and a little more in the brain, but we are nowhere near reaching some kind of a level that would approach an IC90 for the receptors in the brain, because we are talking about so little drug. And this is in comparison to the small molecules, where if you look at the higher doses of both monlunabant and what happened with rimonabant, their levels do reach that IC90 or approach it for receptors that are in the highest centers of the brain. So they really are very different.
Elena and Sean, I'd be curious to hear your thoughts on what you'd want to see in this data to feel excited about it.
Put it in your practice.
Okay, actually, very exciting data. The way I look at the treatment of obesity is that it's a complex treatment. I would say it's analogous to what we do with patients with hypertension. One size doesn't fit all, and one drug is usually not sufficient. You really need drugs from different mechanisms of action. So I like the idea of combining the CB1 receptor agonist together with something, a GLP-1, perhaps a combo, a GIP, GLP-1, some of the other drugs. But specifically about this class of drugs, I've had personal experience in clinical trials, both with rimonabant and with the Novo drug. There has been an issue with the Novo drug. I was part of one of the trials, actually had a couple of them. They were supposed to be moving on to the phase 2AB, which they decided against it. And of course, as Zura just explained, because the mechanism of action is totally different with Nimacimab. It actually is peripherally, and it turns out that it's the peripheral tissues that are really going to be beneficial in terms of the weight loss. It's not the central mechanism. The central mechanism is the one that's going to be associated with the neuropsychiatric problems.
And what was
suicidal ideation, actually, yeah, and that is the reason why rimonabant was taken off the market very quickly. It didn't stay for a long time. Not that it wasn't an effective drug, but of course with the suicidal ideation, and now Novo is facing the same issue because it's central.
Right.
As well.
And what was that one issue that you experienced on the, not you experienced, your patient experienced on the Novo trial?
Not particularly my patients, but this was something that was described in the trial, in the 2A, and that is why it was psychiatric ideation, suicidal ideation.
So it's ideation, okay.
It was ideation. I'm not aware of any fatalities having occurred, but just ideation. There were psychiatric symptoms, because we all go in those clinical trials with a number of different parameters following the patients, more than one group. So this has become very prevalent in a lot of the clinical trials across the board, looking at patients with patient-reported outcomes, PROs.
Got it.
So that was important.
Got it.
Yeah, this was definitely an exciting drug and an exciting time. So back in the early 2000s, so I'm old, I was born in the 1960s, so I was there and around in 2005, 2006 when the CB1 antagonist came out. We were excited. They were sensational molecules. You were getting this visceral adiposity benefit. It was the first time we started to talk about the metabolic effect, not just weight change, but actual metabolic effects on the visceral adiposity and what it was doing inside the gut. And we started to see that it was having an effect throughout the entire body in terms of decreasing inflammation, HSCRP, IL-16, F-alpha, and we started to see changes beyond weight. Of course, when as Dr. Rosenblatt has carefully pointed out, we're about to walk into a room, the presentation is about to be done, and all of a sudden it gets pulled and the doors are closed because of the neuropsychiatric effects that happened. That was a disappointing day and a disappointing time because we wanted all of those positive benefits and none of the bad effects. So now we move into the 2020s, 20 years later, where we're getting the possibility of all of those positive effects that J.P. Dupré is a Canadian who was a lipid doc and did a lot of this initial work. All that work that he did was kind of thrown away to some degree with the CB1s because of the fear. So the idea of it coming back and getting all the positive effects and not the negative effects is really a positive thing. So having a large molecule antibody that doesn't penetrate into the brain and cause those neuropsychiatric effects is a big deal. So what's happening with Inversavo and Novo, and Inversavo is a Canadian company, again, proud of Canada, but also seeing the challenges with this small molecule. So what are our patients seeing? Our patients are seeing the exact same thing you guys have heard. This is not insider information. This is the information that you all got about the neuropsychiatric side effects of montelukast and the small CB1. And so we saw it in our patients, right? I'm involved in clinical trials. We're one of the biggest sites.
For Silas trial?
Yeah.
Oh, okay.
Yeah. So, and we're seeing the exact same thing you heard about, right? It's nothing different. It's anxiety that they don't want. The patients don't want the anxiety. They don't want the stressors. So were these real side effect profiles, or did we manifest them because we had the fear of this happening in the first place? I don't believe it was the fear. I believe there were real psychiatric side effects. Anxiety reached up to a higher level. Depression risk raised up to a higher level. Nothing bad happened because we're in phase 1 trials, right? These 2 trials, so we're able to pull things back. But to be able to have the benefit of that visceral adiposity and inflammatory decreases and not have the side effect profile is what we're looking for. And that's why this is an exciting time to see a molecule. This is when the big molecule is positive and the small molecule is actually not what we're looking for.
Right. Any questions from the audience on CB1 broadly? Lisa?
I might just ask about, I know one of the benefits of Nimacimab is increasing energy expenditure. Wondering if you've seen any increase in body temperature or anything like that might be something to watch for.
We'll be touching on this data tomorrow, actually, Lisa. But yeah, in our recent study, we measured the brown adipose tissue in the scapular region of the mice, preclinically, of course, and we do see a significant increase in thermogenesis. And of course, the uncouplers and browning, mitochondrial density health is all part of this pathway. Haven't measured it ourselves yet, but we do see the increase in thermogenesis. So yeah, we think energy expenditure is one of those elements that'll be helpful. It's probably not the big driver of weight loss with this pathway, but certainly helpful, particularly in the context of lipolysis and lipid metabolism that Sean was pointing to as well.
And Chris, I think you should also identify whether it's increase in thermogenesis good or increase in thermogenesis bad.
That's what I was actually trying to get to.
There's a big audience of increased thermogenesis bad, so we need to get a greater understanding.
Right, and I guess maybe keep in mind too that this brown adipose tissue is more of a phenomenon with the preclinical, and not maybe as relevant in the human setting. In this case, we think that thermogenesis is actually a net positive, so some of that energy expenditure concepts can help with the decoupling of energy, particularly with lipolysis and increased lipid metabolism. We think that's a good thing as a potential outlet. Yeah.
Yeah, bringing it back to the clinical setting, that's where we see this advantage of the combination and multimodal thing. So if you think about it from incretins being able to curb the appetite, and then all of a sudden, you have these other approaches. That's where this complementary mechanism plays an important role.
And we should say that you do need to oftentimes go back to the early 2000s and look at the CB1 antagonists at that time as well. And we did not see a negative in terms of the increase in thermogenesis. We did see all those positive things you were saying. There's been other medications that have come after and other medications that have come before where the thermogenesis was a bad thing. But here, even from the early 2000s, the first iteration, it has not been shown to be bad. And I think that's where we may be seeing a greater loss in fat mass and a possible preservation, or at least not a significant decrease in the muscle mass.
Excellent. Well, I know we're at time, so
I think there's just one question.
Please.
Just a quick question. So how much do you think the efficacy come from the central component from perhaps a small molecule versus peripheral effects?
Yeah, I could, or please, Sean, go ahead.
I think the major benefit in weight management and a lot of the in this field is going to be from the central. The question is how is it triggered in the central? If you have bariatric surgery, which works sensationally for a number of people for a good amount of time and not so well at other times, and if you measure what happens immediately after bariatric surgery, it's all peripheral acting centrally. So if you're not affecting the brain, you're not going to affect weight management in an overall sense. The question is, how do you get that effect in the brain? Is it a peripheral signal that then triggers the vagal nerve and a bunch of other systems that then you can actually measure activity in the brain? But it's not activity of the drug hitting a receptor inside the actual brain. So when we start seeing that, we start seeing possibility of the efficacy and positive things, but you could also possibly see negative things as well, because the brain is a little bit of a challenging area and we don't know when it hits a receptor, what else it's going to do. So we're seeing here peripheral mechanisms heading to central to cause the impact.
That's exactly what I was going to say. I might just add a small detail is we have some data to support that, and it might not be the only driver. We're seeing modulation of key appetite-regulating hormones to make that circuit complete, as you were just talking about, Sean. So we see that data, and we want to look, the vagus, the potential areas of the area postrema, or even in the hypothalamus, there could be some angles there still outside of the blood-brain barrier that can modulate, but we're seeing the hormone data for sure.
And that example, and Sean, you put it perfectly, but yesterday in that great symposium looking at peripheral energy expenditure versus central effects, it was pointed out, and I've used this example so many times, that maritide works the same way as the smaller GLP-1 molecules, right? It doesn't cross the blood-brain barrier. It's a big antibody, but it's got these mechanisms that can hit hypothalamic receptors without crossing the blood-brain barrier. So you can get central effects. They're very important. The key is not to go to those higher centers of the brain and not to cross the blood-brain barrier.
Excellent. Well, from wishing you the very best on your research, and when you do need a multi-GLP, you should listen in on the next session with Sarah.